Hi, this is Elliot Fishman, and welcome to our March 2025 CTisus quiz. As always, we have a series of 10 excellent cases to share with you. We'll present them as a quiz. Think about the cases, think about the answers, and give us your best answer. And with that, let's get started. The most likely diagnosis in this patient with low hemoglobin is, so when I say low hemoglobin, I'm probably trying to infer the patient has had a bleed or a tumor that has probably bled. And when you look at the axial and the 3D imaging, you see a mass in the region of junction of second and third portion of the duodenum. It's better seen on the volume rendered 3D image. It's about 3 centimeters. It's homogeneous. It's mild enhancement. It's not a lipoma. It's not Crohn's disease. That would be narrowing of the bowel, not a mass. Lymphoma is a possibility only because any mass could be lymphoma. It has so many different appearances. You can occasionally have a polypoid mass, solitary or multiple, and can present at times with obstruction or intussusception, but usually would not be so homogeneous. And a better answer would be an adenoma. This adenoma, which is soft tissue density, was resected, and a pathology had increased dysplasia, so it was really a low-grade malignancy. The patient had it resected, and the patient should do fine. The most likely diagnosis in this case is, well, what do I see? On the axial, but maybe easier to see on the coronal, there's about a 2 centimeter mass in the second portion of the duodenum. The mass is exophytic. It's not really intraluminal. It's growing outside, maybe off the wall, and it's of increased CT attenuation. It could be a carcinoid tumor, though carcinoids are usually more into the lumen. It's a great location for carcinoid, and carcinoids usually are more vascular, but there's a lot of variability. It's not a pancreatic mass, so a neuroendocrine tumor of the pancreas is always something you consider for a vascular lesion near the pancreas, but this is away from the pancreas. It's on the lateral wall of the duodenum for the most part. Lymphoma is a possibility, but typically it's infiltrative or polypoid, but when it's polypoid, it's intraluminal. So now we say a mass in the duodenum, which is mainly extraluminal, coming off the wall, that's somewhat vascular. The best diagnosis is going to be C, a duodenal GIST tumor. The most likely diagnosis in this case is, well, what do I see? I see liver lesions. I see splenic lesions. I see subcrural nodes. I see mesenteric nodules and a mass either arising near or from the pancreas, or maybe even the duodenum. So now I'm thinking multi-organ involvement. Lymphoma is a good possibility. Hepatoma usually doesn't go to spleen, and the pattern of the liver lesion, which is not going to be in a cirrhotic liver, and it's multiple, I don't like hepatoma. Sarcoid can involve the spleen and liver and give adenopathy, but the pattern of adenopathy and the size is not really good for sarcoid. This case is really a toss-up. Lymphoma would be a great diagnosis and would be my first diagnosis. If you told me that this wasn't lymphoma, then melanoma, which can involve the liver, the spleen, the kidneys, the adrenals, the nodes, would be a good possibility. This was biopsied and was metastatic melanoma. So whether you said melanoma or lymphoma, give yourself credit, but learn that sometimes you need to think about melanoma. Obviously, if the patient had a history of melanoma, it would be easy, but most of the time, or a lot of the time, patients present like this, and no one has ever made the diagnosis of melanoma. So a good point to remember. The least likely diagnosis in this case, what do I see? I see a large mass, very vascular, that's either arising from the head of the pancreas or arising from the duodenum. So if you said a neuroendocrine tumor of the pancreas, I would say that's a good thought. If you said a carcinoid tumor arising near the pancreas or off the duodenum, I would say that's a good thought. If you said a GIST tumor, remember GIST tumors can be exophytic. They're usually vascular. They can be very vascular, like this case, though I would tend to favor a carcinoid rather than a GIST here. But the one thing I would not pick is a cholangiocarcinoma. Cholangios typically are associated with dilated intrahepatic ducts, dilated common duct, and none of those findings are here. Also, cholangiocarcinomas are hypovascular, so the least likely diagnosis in this case is a cholangiocarcinoma. The most likely diagnosis in this case, what do I see? I see about a 7-centimeter cystic lesion arising off the pancreatic head. An IPMN is a possibility. Remember, IPMNs can have all sizes. There are a few small septations here. I don't see a dilated pancreatic duct, but I really don't see the pancreatic duct well. I do not see a dilated common duct. MCN is usually in the body of the pancreas, can be cystic, can have a thickened wall, can have septations. In theory, it's a possibility, not a great one. A pseudocyst, if the patient had a history of pancreatitis, is always something at least you should consider. But when you look at the choices, the size of the lesion, location, a serous cystadenoma would be a good possibility. Serous cystadenomas, this would be almost an oligocystic serous cystadenomas. Remember, serous cystadenomas have 4 main patterns. You talk about multiple cysts, you talk about tiny cysts, you talk about an oligocystic lesion. This is a tough case. I guess a large IPMN or a serous cystadenoma are possibilities. Irrespective of the choices, you would end up doing an EUS in this patient and then make the correct diagnosis. The most likely diagnosis in this case, well, I see a very vascular mass in the right lobe of the liver, and the liver is not cirrhotic. The lesion has peripheral enhancement. Now, it would be helpful if I gave you the venous phase or the delayed phase imaging, but based on this, I really don't like hepatic adenoma. They're typically homogeneous, low density, some vascularity. FNH does not have that kind of puddling around the edge of the lesion. And hepatomas can be necrotic and very vascular, but again, this 360 degrees of enhancement, no underlying cirrhosis, would push me more to think about hepatic hemangiomas. We're used to small hemangiomas, but they can be large, and they can look at times more aggressive than the typical hemangioma we all think about. And this is a good example of the puddling. If you had images 70 seconds later, you would see the lesion fills in from peripheral to central, and hemangioma would have been a much easier diagnosis at that point. The most likely diagnosis in this case is, well, what do I see here? I see a mass a little under 2 centimeters just posterior to the right lobe of the thyroid gland on the axial images, and you can see it again on the coronal images as well. Lymphoma can give you adenopathy, but this is the only finding, and a solitary node in the region is unlikely going to be lymphoma. Thyroid cancer is a thought, but this mass appears to be near, not arising from the thyroid. Head and neck cancer with adenopathy is a thought, but you don't see any other nodes present, so a single node would be uncommon, but maybe I would think about it. But if you pick up this finding, you see a 2 centimeter or less mass. Often they're vascular. They can be just beneath or just adjacent to the thyroid gland. That's a common location for an ectopic parathyroid adenoma, and that was the diagnosis. Obviously, clinical history and lab values can prove helpful, but think about an ectopic parathyroid adenoma. A really nice example. The most likely diagnosis in this case is, well, what do I see? I see large, bulky tumor pushing the pancreas, surrounding the SMA, extending into the hilum of the liver and paraortic region, and I see it tracking down the mesentery. This is too bulky for sarcoid. Metastatic hepatoma can give nodes. It would be rare to be this bulky. Plus, I don't see a liver mass. This is not an adrenal lesion, so that's not a possibility. This is more likely going to be lymphoma. Lymphoma can give bulky adenopathy. Often it's infiltrating, it's extensive, and the best diagnosis in this case is going to be lymphoma. And this was, in fact, a B-cell lymphoma. The most likely diagnosis in this case is, well, what I see is a mass in the tail of the pancreas that's very vascular and solid and washes out between arterial and venous phase imaging. If you said a neuroendocrine tumor, that's a good possibility. Metastatic renal cell would be a thought, but the kidneys look good. Of course, maybe there's a renal cell that was resected off the kidney, so it's in theory a possibility. Spen tumors are cystic and solid, can be vascular, but typically not this vascular, and I don't see cystic components. And a solid serous cystadenoma. We speak about serous cystadenoma having many appearances. One of them that's tricky is the solid appearance, where the lesion is very vascular and looks just like a neuroendocrine tumor. So if you said neuroendocrine tumor or you said a solid serous cystadenoma, I'll give you credit. This was a solid serous cystadenoma. We're actually doing work now with the radiomics, seeing if we can distinguish a solid serous cystadenoma from a neuroendocrine tumor. We'll let you know what happens. What grade is this renal laceration? You can see there's a deep laceration of the right kidney. There's lack of function in the upper 2/3 of the kidney. There's blood around the kidney. There is a normally functioning left kidney. This is a grade 5 laceration. Renal lacerations are typically considered grade 1 through grade 5. When you have what looks like a shattered kidney with lack of areas of function, you better be thinking grade 5 laceration. It's good to have a chart just above the reading area. So with that, we've had 10 excellent cases. I hope you've got them all right. More importantly, I hope you learned something from looking at some very, very challenging cases. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.